It's my honor and privilege to begin this afternoon's presentation with Dr. Beth Rosellini. She's a fourth-generation dentist who has built a robust evidence-based practice, family practice in Dallas, Texas. Initially trained as a scientific researcher while at undergrad at University of Texas at Austin, she went on to Texas A&M's Baylor College of Dentistry and developed a passion for patient care and clinical research. She describes her philosophy of care that is focused on health care instead of the traditional Western medicine sick care model. She often collaborates with other like-minded healthcare providers in her community to improve patient outcomes through by thoughtful comorbidity management and ideally prevention by proactive care. She has spent the last 5 years devoting more of her time on sleep-related issues, specifically in children, as it relates to optimal growth and development and airway management. Please give a warm Academy welcome to Dr. Beth Rosellini.
So thanks so much for coming. I'm really excited that you guys are here. I'm assuming everyone got to hear Dr. Bergerson this morning. He is the man, the myth, the legend, and so wonderful, so educated, and such an innovator. I was honored to be invited to come speak last spring. It was by Dr. Fisher. It's the first I had really heard of IAOMT. So I came to that conference kind of eyes wide open, but didn't really know what you guys were all about, what we're all about now that I'm a member and have gone through the accreditation process. But after 6 months of going through the accreditation process, collaborating with some of the doctors in IAOMT and starting to treat these patients, I'd like to say I get it, or I get it a lot more. And I'm so excited to be back here because now having treated and talked to these patients and their children and their families as a whole, it has just been so wonderful how we've implemented this and how it just makes sense for IAOMT patients to get this whole preventive sleep disordered breathing. They come in so informed, so motivated for an alternative solution for problems that they have, and then to find out that they have a solution for their kids as well to never have any of those issues has just been really awesome and helped us grow our practice. So thanks so much for coming. I'm going to focus more on the clinical implementation, kind of the real world stuff, less of the research, just because that's Dr. B's bread and butter, and he's the smart one in that case. We talked about our disclaimers. So a little bit, I know I shared my story this morning, but a little bit more history. Actually, a fourth-generation dentist, so my dad and my sister are here supporting me as my dad's first IAOMT meeting. My sister tells the story because she's older than me, so she was in practice before me. When she graduated dental school and joined my dad's practice, all of his patients were healthy. No cracked teeth, no broken teeth, healthy joints, no sleeping problems. She was like, great, but I was hoping to be able to join something more than just a very profitable hygiene program, because there isn't a lot of dental issues that were happening. And what she came to find out was it was because my dad had started treating patients in the 80s with this preventive early interventional therapy, guiding growth and development and getting patients to where they need to be. So many of these dental issues were avoided in the adult population. So it was really exciting, and so she, of course, got trained and was treating her own children and the children in her practice, or in our practice that we're not treating. To go back to my personal story and add a little bit more color to it, not just to prove that I'm a child of the 80s, but I was a very severe thumbsucker, and it caused a host of different problems. I say I was a very sick kid, but at the same time, I was still doing pretty well in school. So I know Dr. Bergerson said that that can be an issue as far as math and science, and I still did well in school. I still played sports. So I was kind of this kid that seemed normal or performing okay, but on the inside, I was definitely struggling with chronic inflammation and had some issues. When my dad found Dr. Bergerson and originally started the therapy, it was before he had developed his night guide or his habit corrector appliance. He only had the tooth positioning ortho appliances. The sleep has been developed. The sleep appliances have been developed since I went through treatment. So my treatment actually started, Dr. B said, okay, Mike, we can treat your daughter, but the first thing you have to do is break her thumb-sucking habit. And so without an appliance, just to let you know how committed my dad was to knowing that this is the right way for me, he actually, so there wasn't anything for my mouth, so he took 2 rulers and took ACE bandages on both of my arms before I go to sleep, so I literally could not suck my thumbs. It was horrendous, and I'm grateful to my parents for living through that, and I can't even imagine, because I would just wail all night. But it broke the habit very quickly. Fortunately, we now have an appliance that will do that for us, but broke that habit. Then I was able to get in the tooth slotted appliance, the orthodontic appliances that are for later phase, expanded my arches, getting those teeth in the right position, switching them, and then, as we'll talk about later, never even having to have a retainer. Talked about Dr. Bergerson. I like to mention him again because everything that he does has been through the scientific method. So he is a scientist and he is a researcher at heart. So it's not a, what's the latest fluff thing to sell to patients? How do we inspire some gig of whatnot? I asked him in our podcast this morning, I said, what would you do if that was all you could do professionally? He said, I love figuring out problems. I love being in the lab and doing the research. He's a great educator, great mentor, great clinician, but that's what his true passion is. So all of the things that we're using as far as the tools that he's developed are based on him tracing hundreds and thousands of Cephs and him looking at so many cases from around the world that I feel a lot of confidence when I got right out of dental school and started doing this, knowing this was based on a methodology that has been proven time and time again, and I could kind of rest on or stand on his shoulders as far as expertise and knowing what the best outcome would be for a patient. Okay, so what am I going to talk about today? I want to delve in a little bit deeper on outward cause and symptoms. So I know we went over that questionnaire, but how do we use that? What does that look like? What are the alternatives? So what are patients hearing or parents hearing when they're in other practices? So not just dental practices, but when they're at the pediatrician, when they're at the ENT, when they're at the speech therapist, when they're talking to their teacher. And then the therapeutic models or options that are actually in practice today. How many of you guys are familiar with Dr. Weston Price? Love it. Oh, that's why I love IAOMT. So if you've read his functional degeneration, nutrition, those kinds of things, he talks about how we went to those different areas where they weren't exposed to the Western diet, and even with no oral hygiene instruction or access to care, the patients had these nice broad arches, their jaws were positioned in the right position, their airway was nice, these patients didn't have tuberculosis, all of these other symptoms. So a big component of my practice, our practice, is nutritional education, because absolutely we can prevent that. I have a handful of IAOMT patients that come to me, and when we start educating them, they tell me, and I see their kids, and their kids have these beautiful, broad smiles, perfect position, mandible, it's going downward and forward. And those are the parents who have had natural childbirth. They were able to breastfeed. Mom was at home with the kid for 2 years, and then they've been living this whole earth type diet. They're drinking raw milk. They're just doing all of the stuff that's right, which is wonderful and awesome. And I would hope that we could all do that, but I'm also very realistic, and I see it in my practice. That's not the norm. So the norm is there's some mix of maybe some healthy options. Maybe it's because we do what's easy, or we do what we know, or maybe it's just they're very uneducated on nutrition, especially as it has to do with growth and development. So I like to explain, okay, we need to adjust your nutritional health and your nutritional IQ, but to make up for this growth and development that your child had, and some of these different reasons why it wasn't optimized. So maybe mom was working and she wasn't able to breastfeed, or all of these different things that can affect the way the child is set up to start growth and development and hit that 2-year pathway. These appliances know where the jaw is supposed to be, and it'll guide it in that right position. So kind of mirroring those two things, increasing nutritional health, decreasing chronic inflammatory symptoms associated with that, and then regaining that space and that guided development that the child needs, strengthening the mandible as far as the masseter, all those kinds of things. It's all really related. And it goes so well with IAOMT type patients because typically they come in very informed about nutrition, or at least having been exposed to it before. A lot of them come from some sort of familiarity with Dr. Price. So if I open with that, that makes sense to them, but then I can identify what the 1 or 2 variables are that have caused their child to have this inflammation, that have constricted the arches and caused the mouth breathing, and it's just a much faster, oh, that makes sense, I'm ready to do the early interventional therapy to correct that. I talk about Dr. Bergerson and his research, and I love this. Is this my pointer? I don't, that's okay. So we can very clearly see exactly where the face is supposed to grow into. So it's not that we're surprised, or as some people will say when they come in and their dental IQ is very low, and they'll just say, oh, I was just born with too many teeth in my mouth. Well, that's not a thing. You're supposed to have this many teeth, but for a host of different reasons, your mouth is not developed to the size that it needs to accommodate the teeth that you have. So I'm a big fan of Liz Lemon. If you guys ever watch 30 Rock, she has a classic eye roll, but I have to stop myself when patients do say something like, I was born with too many teeth in my mouth, or my mouth is just too small, and I was born with my mom's mouth and my dad's teeth. Also not a thing. I was born with bad teeth. Well, unless you have that one genetic disorder and you don't make enamel, which I'm very sorry that would be something anyone would inherit, the majority of the disease that we see in our chair is entirely preventable. And that's where a lot of the education starts, because they've lived in a paradigm their whole lives. Everyone they know goes and sees the dentist, hates the dentist, has dental problems. And so it's kind of readjusting, which IAOMT patients have already started that. That's why they're seeking us out, and it makes it an easier discussion to have. But it's reminding them, this can all, I'm seeing an adult, well, for all the issues that you're having that I'm treating you, we can prevent all of these things in your child by making sure they grow and develop into the place that they're supposed to be. I love using this visual. Dr. Bergerson talked about this morning. I'll show this one first. See, this says laser. Is that? That's not doing any laser. Okay, so basically, as the tooth is erupting, so I will go back. As the tooth is erupting, so this one on the far left is like a 6, 7-year-old, this one in the middle is a 10, 11-year-old, and then this is a 14, 15-year-old. I show this to parents, and I show this to our functional medicine doctor that we collaborate with. I show this to our speech therapist, and I explain the importance of doing the treatment earlier, because as these teeth are erupting, I know you guys are dentists, you all know this, so I'm not trying to tell you something you don't already know, but this visual is really helpful for them, because you can see how little of the root is actually formed as the tooth is erupting. Even as it's entering into occlusion, it's not until the tooth is in full occlusion that the full root and the apex is formed, and all those collagenous fibers are formed around that tooth to hold it in place. And once you see this, it makes a lot of sense why traditional ortho ends up having to have a permanent lingual retainer for a lifetime, or they end up having relapse 90% of the time, and they have to do adult Invisalign, because we're waiting until a child is 12, 13, so they're through puberty, they have no growth and development left, and they have all their collagenous fibers hooked into those teeth, and we can twist and we can move and we can push to get the teeth in the right position, but those fibers, that's funny. You have to turn this on for it to work, so that's strange. But these collagenous fibers, you can try to tear them, all those kinds of things. Eventually, they're just going to spring back unless you glue the teeth to where they need to be. So that's that permanent lingual retainer that so many of my patients end up have. But if you capture them and you create the space that they need, you guide them in to where they need to go, such that once they're in the arch and the roots start to be formed, those fibers start to glue into them, you have a natural retainer. The body is going to keep that where it is, and we have no relapse. Does that make sense? Yeah, can I get a show of hands? Because I feel like that's really important. Okay, cool, thank you. So there's a lot of different things that we can identify as far as the mouth, but then having a survey that can identify some of these inflammatory symptoms as we're getting used to seeing this in our practice or talking to patients about it, there are a number of different ways that we can start seeing and screening and diagnosing this. So some of the symptoms that we talk about are, I'm sure everyone can think of at least one child in their life that's suffering with at least one of these symptoms. Is that accurate? Show of hands? Yeah. And then if we really sat and thought about it, there are probably a lot of kids who are suffering from even more of these symptoms than we would expect. Here's the list of this study that was done, the incidence of sleep disorder breathing symptoms in children from 2 to 19 years old. They had 900 patients that they tracked. And this was the percent incidence of those children with these symptoms. 90% had at least one symptom, 60% exhibited 4 or more. From 4 to 12, 93% of the symptoms did not get better, so the classic, they'll grow out of it, is just not true, and it's been proven. And then 30% of the cases, those symptoms actually get worse with age. So if they're not getting the space that they are needing, as an example, if they have the lingually inclined maxillary incisors, it displaces the mandible backward, and so it's never getting the growth that it needs down here. As they grow the airway, they need more oxygen, they need more airflow, they're just not getting it, so those symptoms can get much, much worse in a short amount of time. So I show these percentages, and we see how often this happens, and we say, oh, okay, that seems pretty bad. But when you actually start looking at kids in the face, in your practice or in your community, you see that they're like tiny little worn-out adults who have been burning the candle at both ends. And they don't get the benefit of drinking coffee and saying, I'm exhausted, because they're just assumed, oh, you're young, you're a child, you have lots of energy, what are you talking about? Or if they complain enough or their behavior is aberrant enough that they may end up getting medicated and going to see a doctor or a physician that doesn't know how to treat it otherwise with some medications. I like this slide. I know Dr. Bergerson showed this morning, and I always show this to parents because I say, you know, this is your brain on sleep, and this is your brain on no sleep. So expecting a child to be able to go and learn and grow and play at school when they haven't had the restorative kind of sleep that they need, not just one night, but multiple nights in a row, or maybe their whole lives, we kind of begin to empathize in a different way with these kids who we may say, oh, well, that kid's just a twerp, or that kid is just doesn't listen, or he's so poorly behaved, or it's mom's fault. Well, no, maybe mom doesn't understand. Kid doesn't know how to communicate how he or she feels, and they just have this chronic buildup of that beta amyloid plaque and not getting any restorative sleep, so the child is just miserable. I mean, it's amazing that a kid with some of these symptoms can even function in real life when their brain isn't functioning all that well. So there's a million studies, not a million, that's hyperbolic, but there are a lot of studies that Healthy Start has accumulated to help us educate our parents and our patients, which I really appreciate. We actually have them downstairs at the booth if you want to go and take them home to start educating your patients and your parents. Some of the ones that really stick out to me, children 6 to 9 years old with less than 10 hours of sleep were 1.5 to 2.5 times more likely to be obese. That's a huge, I mean, Michelle Obama had her huge initiative was getting kids moving. Childhood obesity was a huge problem. Well, what about get kids sleeping? How would that have improved childhood obesity? Allow them to sleep, allow their cells to have that cell turnover, allow their hormones to be in balance so that they have hunger and all those kinds of things in balance. On top of that, when they're not sleeping, they crave that high sugar, high glucose, give me a burst of energy type food, which is obviously going to predispose them to having diabetes or just weight gain or those kinds of things. So it's all related. But if they're sleeping well, they don't crave those high sugar foods, and so they are less inclined to present with overweight or obesity. So my sister, who's also a dentist, she's here, and she's been doing this for longer than I have. She has, I don't want to say accidentally, but she kind of in our community became the person that difficult children started to come and see. Like when parents were so desperate for a solution and couldn't find one with other providers, they ended up in her practice. And it's been, I think, really rewarding for her. I think it's also been very challenging. But as a result, she's ended up seeing a lot of special needs children, children on the spectrum, and Down syndrome children. These kids struggle with sleep so much. And so many of their symptoms can be relieved, or their quality of life can have an improvement with a very short time frame of wearing the positioner that brings their mandible forward, reinforces nasal breathing, and allows them to get that restorative sleep so that their brain is not proverbially on fire, and they can function and their brain can fire in the way that it's supposed to. I mentioned, I think it was to someone, so if I hadn't mentioned it here before, the current, actually I'm going to talk about it here in another slide. We're going to talk about Down syndrome kids that she's been treating. It's really been remarkable. But we see it a lot with our psychosomatic, our neuro patients, pediatric patients. It all comes together. It's associated with sleep. Once we get sleep corrected, we can get almost complete correction, if not total correction, of those symptoms that they're presenting with. So seeing that collapse, the child has a very, very small airway. I like to show this photo to parents, because classic, a picture says 1,000 words. They get this. We even have a tube of how big a normal adult airway should be, a compromised airway, and a coffee straw, to be able to hand that to them and say, okay, during the rest of the time that I'm talking to you, parent, I want you to breathe through this straw so that you understand what your child is doing at the same time as we're talking. And oftentimes they can only do it for a few seconds before they're out of breath and very uncomfortable. CBCT has been a great addition to our practice as far as education, because when you can show a photo that just says, hey, and we simulated this, so we had a patient normal with a good airway and then opening the mouth to see what can happen to the airway. When we say, hey, the mandible is basically a foot on your child's throat. If someone was standing on your child's throat, would you do something about it? And the parents are like, well, obviously, of course I would. Well, that's what's happening with the mandible, so let's do something about it. And I really try to imply that urgency to help them understand just how severe this problem is. And even if you don't have a CBCT in your practice, you can still use tools like this to help educate parents and say, with a child with the kind of profile that your child has, that Bart Simpson profile, that Napoleon Dynamite profile, I know with certainty that that's probably what their airway looks like. Or if they're sleeping with their mouth open, we know that they're getting a reduction in their airway. It's also a really great way to build relationships with your oral surgeon. If they have a CBCT, you can potentially set up a referral process to ask them to take scans on your patients to look at their airway. This is that profile that I'm talking about with the retrognathic mandible and knowing that there would be a restricted airway. And this is a child breathing through a variety of 3 different straws, showing just how much the airflow will be restricted. So just getting it down to 1 millimeter, so that would be a 7-year-old who opens his mouth ½ an inch, which would correlate to 6 millimeters of collapse in the airway. So he's left with 1 millimeter. He's only getting 11% of the airflow he's meant to have. And if he's breathing like that all during the day or all during the night, or if he's breathing like that just for a couple of hours, that's still not a good result. When we do sleep studies on some of these kids, we'll see, okay, the kid is desatting 15 times throughout the night, and he goes from 97% oxygenation, and he drops down to 90%, 89%, 88%. That's the equivalent of if an infant were in the NICU, the whole team on the whole floor is being called in to figure out what's going on with that baby, if they're getting that little airflow being recorded. So that desaturation has a major effect, whether it's happening all the time or just for isolated amounts of time. So the target things that we're looking at are mouth breathing, narrow palate, improper tongue placement, and the relationships of the jaw. So ideally, if you take nothing from our talks today, I would hope that these 4 things would be takeaways that you can start looking at your patients and screening them to start a conversation about sleep. Even if you decide, for whatever reason, that you don't want to include this in your practice, which I would want to talk to you afterwards to find out, but even if you don't, you're helping that patient, you're educating them so that they can seek treatment with a provider in your area that does want to do this. But I think what you'll find in a lot of communities is there is no provider who is an expert in this. Ideally, I would hope that you guys would be inspired to want to become that provider so that you can help the children in your community and help the families in your community. But these are the 4 things that we're looking for whenever we're screening them. Some of these symptoms, it just, when you actually sit down and think about it, the bedwetting, stunted growth, the night terrors, the aggressive behavior, how we're currently treating them is wild. The accepted standard of care of medicating our children, sometimes I have parents come in and they fill out the prescriptions that their child is in or taking, and I mean, it sounds like a scene from Studio 54. They're on uppers and downers, and they're on shakes, and they see this therapist, and they're doing this kind, and I'm like, this kid is 7 years old. Like, how is this kid this sick and on this many medications? It's wild. Add on top of that, it's not as if these medications are introduced and then all of the problems are solved. We have a plethora of side effects of them getting on those medications in the first place. So is that actually helping the situation, or, I mean, I could go off on a tangent as far as the pharma company that appreciates that the child just is going to be medicated for the rest of their life and how that's a wonderful business model for them. But is that in the best interest of the patient? As a practitioner, I would say absolutely not. Taylor Swift reference for anyone who is also a child of the 80s. Those stimulants, those oral medications, those are classic Band-Aids over bullet holes. It's not even coming close to addressing what the real problem is. It may help a tired kid be stimulated enough to make it to lunchtime or make it to the end of school, but that is in no way a quality of life or systemic health that we would want to establish. What's the root cause of that child being so tired and needing that extra stimulant? CPAP is, now that Airway has been talked about more recently in the last decade, prescription CPAP coming from a sleep medicine doctor is more prevalent. This is a story of one of my sister's patients. She had dental issues. She's a classic sleep disorder breathing patient, but she had gotten a CPAP because that was what was covered. This all happened before she came to see my sister, but she had a CPAP. It was covered by the program that she was a part of, and she said it helped her, but one weekend, I guess, parent forgot to pay a bill. The electricity was turned off. She couldn't plug in her CPAP to be able to sleep at night. So to have her quality of life diminished because of that, and the access to care and the knowledge for the patient to know could be just a very simple intraoral appliance that brings her mandible forward, opens her airway, reinforces that nasal breathing that could solve her problems. Fortunately, she's in treatment now, so that's heartwarming, but that's certainly not the best outcome. And also, and I'm going to talk about this a little bit more when we talk about the children with Down syndrome, but the CPAP, if you have a child, especially with Down syndrome, that's putting pressure on the maxilla, and it's decreasing the advancement of the maxilla. So we're not getting that same optimal horizontal growth that we want to see from the midface. So it's not even clinically the best outcome as far as guided growth and development. One thing that I've really enjoyed about what I've learned with IAOMT is oral galvanism. Didn't know that was a thing, but now I'm much more educated on that. And it's made me look at things like bands and brackets and wires and headgear in even more appalled state than I had previously, because these kids are growing and developing, and then we put these harsh mixed metals in their mouth, and we're pulling and putting these unnatural forces on their teeth. How uncomfortable that is, how not great it is that they're swallowing with all that in their mouth every single time, when it could all be avoided. They could have something that's very compatible with their system and just metal-free. So the issues that we see when this isn't treated at an early age, for the dental issues for parents that we see in our practice, obviously poor aesthetics, but then we have premature tooth fracture, tooth wear. Our teeth are meant to hit together in a certain way for a certain reason, and when they don't, that's when we get cracked and broken teeth. They have TMJ issues, sleep apnea, increased risk of periodontal disease, decay. It's more difficult to keep clean. They may end up having surgery or losing teeth prematurely, and sometimes they end up having a lot of decreased function. On top of that, we see patients who have chronic pain, they have sleep apnea, and all these other inflammatory symptoms that once we get their sleep on track, a lot of those things decrease. As dental professionals, as intimidating as I think it can be sometimes, or maybe that's too strong of a word, but we have already a lot that we're focused on and a lot of responsibility for our patients, and this is one more thing. And the United States is a place where orthodontists, in my opinion, kind of protect what they're doing, and they kind of have this black box. I remember in dental school where they just said, here's a Ceph, you're gonna see what it looks like to know how hard it is so that you never wanna do this when you get out in practice. So I graduated not really understanding a whole lot. Of course, they're wonderful orthodontists who collaborate and help, and I'm fortunate to have met them, but that was kind of my experience with education. But I was empowered to see these patients because I had a great mentor in my dad, and I knew Dr. Bergerson, and I just knew my responsibility. But then once I actually started getting in practice, I realized there's no one else besides a school teacher who sees children more than we do. We're seeing them maybe 2-3 times a year. Pediatrician, first couple of years, they're seeing them more often, but once they're done with their vaccine schedule, they're going to less and less frequent visits. Unless they're seeing a speech therapist, they're not seeing a specialist or a healthcare professional on a regular basis. Even if they are seeing someone, let's say, they certainly aren't seeing someone who's an expert in the airway, dental arches, that are doing these types of screenings to see if they may have sleep-disordered breathing. So I'd like to say, yes, here's a great opportunity. We should all do it. It's more of a, holy moly, this is an urgent need for our children. We must do it. And it's one of the most rewarding parts of our practice. I know Dr. Bergerson mentioned this morning, but I've never had a patient come up to me and be like, oh, Dr. Beth, that MOD composite is beautiful and you changed my life and I love it. Or like, I'm so grateful that you got this crown to seat in less than 10 minutes. You must be have such good hands. That's never happened to me. But these patients are the ones who, I'll be at my niece's or nephew's school, and a patient will run down the hallway and be like, hey, Dr. Beth, what's up? Are you coming to my soccer game? They're these vibrant, happy children once they've been treated and they're put on this pathway to being the best versions of themselves. And these are the parents who become word of mouth, insane like champions for our practice because we've changed the quality of life of everyone in their family. If child is doing well, you better believe parents are doing a whole heck of a lot better. But when child is struggling, parents are struggling. So fixing the root cause of the problem is fixing so many things for the whole entire family. I know that the ADA is kind of a touchy subject with this group. So mindful of the many different opinions on the many opinions that they have, I am grateful that in the last couple of years, they have identified that dentists are a very great resource for preliminary screening of sleep disordered breathing and the symptoms associated with it, and that there is a bigger impact of these conditions on these children, that we should play a more active role in helping those patients. So again, I know it's a divisive topic, but I think in the sleep space, they're doing some good work. So what's the solution? We talked all about the problems. Hopefully you guys are convinced of how urgent this is and we got to do it. Diagnose early, or screen early, diagnose early. Talk to families. Even if you don't treat that specific family, they are going to know someone in their community that this could help. Eliminate those poor oral habits ASAP, ideally without the rulers, but if you have to. And then early interventional therapy. So it never gets easier. As I mentioned, 30% of the time their symptoms get worse. And those younger children are more compliant. They are happy to do things when you wait until teenagers have, not only do they not have any growth and development left, but they might have not been sleeping for 12 years. Add on top of that raging hormones. Good luck doing anything with those types of patients. They're very challenging. So that early interventional opportunity is just wildly successful for those host of different reasons. So there are a lot of different diagnostic tools that you can use. We implement a lot of them, But I want to emphasize, you don't actually have to have any of these to start the conversation. You really just need the questionnaire. So we're gonna go over that, but I wanna talk to you about the tools because I do think they're really helpful in education. We have a handful of different home sleep tests that we use. This is helpful for our parents who are not convinced or really can't understand the gravity of the situation, but as soon as we can quantify it and say, hey, your child woke up 27 times last night, and all 27 times they had an apneic episode, so no breathing, and anytime they had an apneic episode, their resting heart rate went from 80 to 130. So they're having increased cortisol, they're having no restful sleep, they're tossing and turning. Maybe they're not waking up and coming into your bedroom, or they're not telling you that they're tired, but this shows you very clearly how unhealthy your child's sleep is, how much they're compromised as far as their recovery and the oxygen that they have. We have got to do something ASAP. And that really resonates with a lot of our patients. Also, this really helps with physicians who are not used to thinking about this. When we can quantify it and say, hey, ENT, that child that's been difficult that you did a TNA surgery on and still is chronically inflamed, have you looked at the mandible? Have you looked at the arch widths? Have you looked at the tongue placement? Here's a sleep study we just did, and they've been in the appliance for 3 months and all the symptoms have gone away. Now our ENT is one of our best referral sources. The CBCT, I mean, it's just such a wonderful tool. It's an investment, of course, but there are ways in your community that you can get access to these types of scans. And patients really, to be able to show a before and after with the CBCT after they've been treated, or just to start with that before and show just how compromised their airways are. But really, this questionnaire is all you need to start the screening process and start the educational process. One thing that's been really great with IAOMT patients, so I get a lot of patients who found me on the website or found me on our website, and they're adults, and then they're sitting in our waiting room, and we have these out there. And this starts the conversation. They say, hey, I've never been to a dentist who asks if a child wets the bed. What's happening here? What are you doing that's different than every other dental office? Hey, I saw this about mouth breathing. Why is that bad? And then every single patient, adult and child, but especially our children, everyone fills this out. It's our standard of care now. Even if a patient says, well, I'm just here for a prophy. Okay, well, you have to fill out this form because I have to know what I get your blood pressure, I get your update on medical history and medications, and I need to know these symptoms because this has a much bigger implication on your overall health. And if I don't get that information, I can't give you a full scope of care. And this has helped us, I've been surprised, this has helped me identify patients who I wouldn't have even thought might have those kinds of symptoms because they're thriving and they're in great health, but in fact, they have a very restricted airway, and by getting them into treatment, their quality of life goes from thriving to just even more so. This demo might be a little cheesy, but I say early intervention is like molding wet clay. Kids are so spongy and they're so easy to guide and develop, and that's when we want to push those arches to where they need to be so those teeth can come up exactly where they were intended for. Whereas a traditional ortho, wait until they're done growing, is like a mosaic. Wait until the clay hardens, break it, and then glue it back together. And it doesn't end up being the same pot. These are what the appliances actually look like. We have the habit corrector appliance for all the different ages, and then the 2 slotted appliances. There are 34 different appliances, so it's not as if every single child gets the same tooth-slotted appliance, but part of Dr. Bergerson's research was based on the mesial distal width of 24 and 25. He can, within I think 99% accuracy, predict exactly how big the arch needs to be so that you can get the exact right appliance, and all the remaining adult dentition can be guided into those templates. The habit corrector appliance, so this is in place of the rulers with the ACE bandages, is putting the tongue in the right position, it's reinforcing proper swallowing, it's getting the jaws in the right position, and it It even has a myofunctional component of it. If the child has a weak buccinator, weak facial muscle, that they can use the tab, which is a really common myofunctional therapy that you'll see. The actual orthodontic appliance, or the tooth-slotted appliance, is an activator positioner with the combined biting source. So, my apologies, I'm not perfectly informed on the new research, but saying that the active wear of the appliance, so this is kind of a softer plastic. We have patients who need additional force to move the teeth, do what's called active wear. That means that they're biting into the appliance for about a minute when they're awake, and then they relax for about 30 seconds. There have been some studies shown, I'm not sure on the metrics, but that increases blood flow. It's basically like you're working the teeth out, so you're getting more osteoblasts, more osteoclasts in the area, so you're helping remodel that bone more rapidly than if you were to have a fixed wire on that gets positioned day 1 of the next month, and you get a lot of force that first 3 days, and then it's just holding them there. With this active wear, they're getting new forces on the teeth every single time. They're bringing that blood flow so that the whole month they're actively remodeling their bone and getting those teeth in the right position. Guiding that growth and development while also telling the teeth where to go at the same time. So this is one of my sister's patients, and I just really like this case. The mom became such a proponent. She sent us these videos of her kiddo, so we didn't even ask her. I don't know if you can hear it. Oh, I don't know if my sound is on. Is that some way we can set that up? If not, I can just talk about it. Essentially, and we'll see if we're able to do that, but if not, here he is. He's not mouth breathing, but he has very audible breathing through his nose, a snore through his nose, and he wakes up often. We put the appliance in, kind of like that Eli video this morning, and he is asleep, no audible breathing, and mom had him in it for, I think it took the first couple of nights. She'd have to wait until he goes to sleep, and she would help put it back in the appliance because it would sometimes fall out, and now he sleeps through the night with it. Oh, but the alternative therapy that my sister discovered, because she's been collaborating with an ENT at UT Southwestern in Dallas, was that the child will, a child with Down syndrome who has a restricted airway will undergo multiple rounds of general anesthesia. They'll have ear tubes placed, they'll have tonsils and adenoids removed, and then oftentimes they'll get a rapid palatal expander glued into the roof of their mouth, all while they're asleep. That's also multiple rounds of staying in the ICU for this type of patient. All of that is being done prior to exploring an intraoral appliance therapy to bring that mandible forward, help advance the maxilla, decrease the chronic inflammation that may be causing some of that tonsil inflammation. And so she's had really great success, and the ENT has been very open-minded and co-treating and seeing if this could be a first step prior to that accepted protocol that they've been doing for years and years. And parents love it. On top of that, they do a procedure called tongue shaving. I didn't even know what that was, but they basically reduce the tongue surgically. I mean, I don't know anyone who would prefer to be put to sleep multiple times, stay in the ICU, have tens of thousands of dollars worth of surgery, have something glued in my mouth, have my tongue cut, have ear tubes placed and my tonsils removed before at least trying an appliance to see if that helps. But that's the standard of care that a lot of these kids are experiencing all over the US. Swallowing is an interesting metric when you think about the forces of our body, and I know Dr. Bergerson talked a lot about where your tongue is supposed to be in the roof of your mouth, kind of broadening that arch every time you talk, every time you swallow. So we're swallowing about 2 times a minute during the day, 1 time a minute at night. That's about 2,000, 25,000, or 2,500 swallows every single day. Well, if someone has a tongue thrust and they are told they have a tongue thrust and there's a speech issue, maybe they get sent to a speech therapist, and they're going to see a speech therapist for $80 an hour for 1 hour a week. So maybe they're getting 120 swallows, where they're being reinforced actively while they're being watched where their tongue needs to go. I'm not discrediting that therapy. They're very smart and they do a lot of really good things, and we collaborate with the speech therapists in our community. But what's great is when we can get, I don't know, all 2,400 swallows in the right position every single time. And that's what that habit corrector appliance does. It has a little lingual shelf, so it puts the tongue upwards, but it has two kind of little prongs that makes it not push against those front teeth every time it swallows, every time the child swallows. So child eventually learns where that proper tongue placement is, and this has another effect in that those adult patients who were treated with band and brackets and have a lingual retainer on the bottom, okay, maybe the lingual retainer is still straight, but if the anterior tongue thrust was never treated, you better believe that they're going to have relapses as maxillary incisors. And then they're going to be in adult Invisalign or some clear liner to try to repair it, and it's not their fault, but they were just never educated on the fact that that was the root cause of why those teeth were getting flared in the first place. And unless those were permanently retained, which I really am not a big fan of permanent maxillary anterior teeth retainers. I don't know if you guys have ever seen that, but we've seen a few of those. No, just put the tongue in the right position, and then we won't need that permanent retention. So the actual reasons for crowding, lower permanent incisors are 5 millimeters larger than the deciduous, upper permanent are 7. So if you see a 3-year-old or a 4-year-old and they have all of their deciduous teeth, and you can't get a gauge that there's about 6 millimeters of interproximal spacing, they're going to be crowded. Dr. Bergerson has a great study on showing that that doesn't self-correct. You need that space. So the sooner we can get in there and create the space, the better outcome the child's going to have. So if you see a child, and this is where parent education is really important, because a parent may look and see all the teeth are touching. Oh, but my child has such pretty teeth. Well, that's actually not what healthy teeth should look like at that age. They should have 6 millimeters of spacing. What is not causing crowding is that there's some unusual difference between the deciduous and the permanent teeth, or that the laterals are bigger than the centrals, and vice versa, or just the arches were not, I got my mom's mouth but my dad's teeth. That's just not the root cause, but that's what people think, or that's what they're led to believe, or that's what they've heard someone tell them. The reason why people can end up with straight teeth, so all of Dr. Price's non-westernized patients ended up having straight teeth because they erupted straight. The mandible and the maxilla were in the right position, they were not inflamed, they were not breathing through their mouths, they had that spacing, and the teeth were given the opportunity to erupt where they were supposed to. So a dental solution to a medical problem, straight teeth being really important, but actually improving someone's quality of life, making a big difference. So this child, let's see, this child had, when he originally started wearing the habit corrector, was a 5, meaning all the time he was wetting the bed. And then after wearing it for a few months, he went down to a 1. On top of that, you can see how severe his deep bite is. And this is the type of kid that more than likely was doing fine in school. Maybe he didn't have those cardinal signals of behavioral disruption or any of those things that I've really emphasized. That's how a lot of patients can end up going untreated, because they say, oh, well, the kid's happy and he's doing okay. But if you're actually screening and you're asking the right questions, you're going to see that 90% of patients who really are struggling in one way or another. Correcting his deep bite so that positioner keeps the maxillary teeth in the right position, allows the super eruption of those posterior teeth to correct that deep bite. And just ends up with a beautiful aesthetic result, but medically is a much healthier child. Different case, similar result, came in, he 2s, 3s, 4s on all of the symptoms. So he's hyperactive, he's having excessive sweating, he's attention deficit, restless sleep. I mean, my goodness, this poor child and this poor parent, this is how he came in, 100% overbite. That's where he ended up. Had that downward forward growth of the mandible, proper jaw relationship, kid's a much healthier, happier kid. Seeing the before and after on some of these cases, it started, and Dr. Bergerson was awesome. I think it was back in the 80s when he was on the cover of Chicago Sun-Times, and it said, "Look, Mom, straight teeth, no braces." And that was I think, reason enough for all of us to have switched to this kind of therapy. All of the additional systemic health implications have just been a major addition. But these kinds of results, without having to have all of that metal, 2 years of treatment, periodontally compromised, hygiene compromised, that alone should be really inspiring. And a lot of the IAOMT parents really get that. They're anti-metal, they're very pro-hygiene, they're anti-unnatural forces, so it's very synergistic with the message that they're already seeking for themselves. This is actually the appliances in place. It turns kind of this frosty color. That's how you know the child's been wearing it. So there's a good accountability factor built in. The other thing that I really like as a practitioner, being very real world with you, is I spend, I'd say, 95% of my time educating, 5% of the time confirming clinical things, but the majority of this is delivered by my assistant and my hygienist. And they love that, because they're now doing things outside of the scope of care that they've traditionally been trained in, but they're also in our community. So these are their kids' friends and the kids they know at school that they're helping, and the parents are their friends. So as far as a practice builder and just a community improvement and having a positive impact on the people that I see every day, it's one of the greatest things I think we've ever had in our practice. This is, again, one of our Down syndrome patients, or one of my sister's Down syndrome patients. This child, it was so intuitive and felt so much better after he had been wearing the habit corrector that he would go and get the appliance and put it in, and he would wear it during the day without being asked, without the parent asking. If that is not impactful as far as proving how a kid doesn't need to explain, doesn't need to be educated, he just knows what makes him feel better, and he would go get that for himself. This case I'm a really big fan of. This crowded case, this child came in, I think at 7 years old, 6 years old, and severely crowded, similar to me in that she was told by an orthodontist that she would be an extraction case, wait until she was done growing. We didn't use anything but the Healthy Start appliances. She was wearing it just at night, wasn't doing any active wear, and we guided her into this super aesthetic profile. So instead of entering that quote-unquote ugly duckling phase that we were taught in dental school, that just everyone happens to go through 7 to 10 years old, this kid has more confidence. I mean, her mom talks about, like, maybe you could help take her confidence down a notch or two. She's just too vibrant and too excited. But she's the kid that we see when we go up at school, and she says, "Hi, Dr. Beth, do you want me to go and talk to anyone about my appliance? It's going so well. Look at my beautiful smile." She's never going to have braces, and she's just a rock star. So to see that we went from that amount of crowding, just wearing the appliances at night, correcting her oral habits, and ending up with that arch, just ideal U-shaped arch, is really rewarding. Last thing I want to mention is, I'm not sure if you guys have had this experience in your practice, but the IAOMT patient, we see a lot of women who struggle with fertility issues. So women who have sought alternative ways of increasing their fertility through nutrition and hormone balance, and our integrative medicine doctors are seeing them and then referring them to us. It has been awesome to start the conversation about breastfeeding, growth and development for their kids, what we can do for airway and sleep for both them and their child. So it's a whole family, it's the whole practice. Everyone gets to hear about it, whether they have kids or not, because it's kind of on all of us to help these kids that are struggling so much. That's it for me today. Thank y'all so much for having me.